Well, good afternoon, everyone, and welcome to the Choosing Hope 2 webinar series. I'm Lisa Green, and I am a program coordinator at the Western New York Rural Area Health Education Center. This series was planned through R-Corps over 3 years, but of course we've had a pandemic over this last year, and it's really thrown into relief how much this kind of programming is needed and how much we still need to choose hope in substance use issues. It's just been a really trying time for a lot of people. And I wanted to share a couple of things from an article that I recently read. It's from MedPage Today. Christina Fior, the Director of Enterprise and Investigative Reporting, reported this on March 2nd of this year. Claims for overdose among teens rose 95% in March and 119% in April of 2020 versus those months in 2019. And substance use increased 65% and 63% respectively in that time period. Those trends are consistent with recent CDC reporting that found the highest number of US overdose deaths ever recorded in a 12-month period, over 81,000 for the 12 months ending in May of 2020. Overdose deaths were already increasing before the pandemic, but the rate certainly accelerated. So, just some notes on how serious the matter is. But we welcome you today. We're so glad that you're here. And we've got some really great folks to talk to today. Just a few housekeeping items to start out with. We have the chat box, and please don't hesitate to break in with questions or comments in the chat box. Introduce yourselves. Any comments are welcome. I will be watching the chat box to make sure that if you have a question that I can relay them to Cheryl and Caleigh. And this is your lunch hour, so I know some of you may have to jump off after some time, and that's fine. This session and all the sessions in the Choosing Hope 2 webinar series will be recorded and available on our website. And I'll send you links after the series is done. If you have questions or you'd like to connect, my email is lgreen@r-ahec.org, and that will be presented later in the program. So please take note of that, and you can connect with me, and I can connect you with our presenters as well. And before we begin today's session, we'd like to start this series off with one person's story. Her name is Cheryl, and she is a survivor and someone who truly believes in hope and recovery. So welcome, Cheryl.
Hi, I'm Cheryl Netter, and as Lisa said, I am a person in recovery for many, many years, and I am grateful for hope and recovery. And I'm here just to share my story, a little bit about me. I grew up in a very small town, and I have come to the realization that part of the reason I drank and used was because I saw that in my father, who he had gone to World War II. He was the only person in his troop that came back alive. So he saw all his friends taken in the war. He had substance use disorder all my life growing up. He drank and to excess. And I now know through my journey and what I have learned that he was coping with everything that he had lived through by using alcohol to self-medicate. So in growing up, that is exactly how I saw how you coped. So as my life has progressed and I've done a lot of self-reflection and things, that's part of the reason that I did use and drink myself, because I saw that as a coping mechanism, as so many people do. I am grateful that I did not have the substances that are available to younger people today. I mean, with the fentanyl and all of that, I'm very grateful that I didn't fall into all of that, because that makes recovery even more difficult. But I did a lot of self-reflecting. Part of my recovery has been due to the fact that I have always felt very strong about being honest and open about my recovery. I am also a suicide attempt survivor. Um, and again, back to the self-medicating part. I grew up again in a small town. I lacked self-esteem. I did not have a lot of self-esteem at all. And all through high school, um, I was participating in acting, and I did a lot of creative writing, things like that. Those were tools, even though I didn't know I was using them as tools. A lot of my writing, however, was very, very dark. I talked a lot about death and dying and all of that, which now we know could have been a red flag, but back then it wasn't really considered that. It was who I was. So I grew up and got married young, and my husband and I both drank a lot, and we used also together. Um, and as I got into my 20s, I started feeling more out of control and couldn't understand why. My doctors were telling me it was just a woman problem, and I knew it was more than that. I just knew it was. And one day I called my doctor's office up, and I was in hysterics because I always felt like two different people. There was a person that was reacting, and another person that was looking at this person reacting, going, oh my gosh, how can I get this person in control? And I was explaining this to the receptionist. And like I said, I was hysterical at the time. I feel bad for her now that I think back on it, because she probably was, oh my gosh. So she got the doctor anyway on the phone. And that's when my journey toward my health and recovery started. One thing led to the next, and I was referred to my my primary physician. I was diagnosed with depression at that point. So I was put on medication, and I got to a point with this medication that I became immune. I mean, it didn't work anymore, and I would start sinking again. And with each episode of my sinking back into the dark pit, is how I used to call it and write about it, I would start drinking more and using more again. And what I was doing was escaping what was going on inside myself. So from there, I went into the hospital for mental health reasons, and I was diagnosed with severe depression. So when I got out, I was put on some other medications. And again, same thing happened. I got to the highest level of a dosage, and then it just stopped working. So I would sink back again. And I ended up, I had 2 daughters at the time, and they went through this journey with me. Now they are both stronger women because of it, but back then I carried a lot of guilt for everything I put them through. Even though it was not a fault of mine, I still carried that guilt. And that was another reason that I drank and I used. So as I said, I got diagnosed with severe depression, and then ended up in the hospital again. Now, each time I went into the hospital, I was going to a counselor who would start to see signs and symptoms within myself of suicide ideation. And so he would recommend that I go to the hospital, which I was always compliant with until the third time this happened, and I was not going to go. So he told me he would have to call law enforcement in and, you know, force me to go if I didn't choose to. So I went, and then I was diagnosed with bipolar disorder. So each time I went in, I was drinking, I was using, but again, it was my escape mechanism. I was self-medicating because I didn't know how to control or how to recover from what was going on inside me. So the fourth time that I ended up in the hospital was because of attempt to suicide. And I was on several medications at the time, again, still drinking, still using. And all I can say is I got up one morning for work, and it was not something that I had been contemplating. It was a snap within me. And I had something happen the day before that was devastating to me at the time. And I woke up in the morning, got all ready for work, went to take my medications, and overdosed. I ended up in the hospital in a coma for 3 days. And the doctors did not think they'd pull me through. Now, I believe in a higher power, and I believe that higher power has had his hand on me my whole life. And I believe that it's only by the grace of my higher power, God, that's who I call him, that I'm here. Because again, the doctors did not think they'd pull me through. They called my kids in, they called my husband that I was separated from at the time in. I had a boyfriend at the time. They called him in, my mother, my brother, my whole family. And they said that they probably would not pull me through. And after being in a coma for 3 days, I was finally deemed in recovery. However, the journey didn't end there, and still hasn't, because every day is another day in recovery. But again, part of the strength that I found was telling my story. I found that opportunities opened up to tell my story out of nowhere, I thought. And years later, people come back to me and say, you don't know what telling your story at that point in my life meant to me, because I was going through ... And I didn't know that, but I felt each time I told it, I gained strength, and strength in myself, strength in recovery. And I sit here today saying recovery is possible. Is it scary? Yes, it is. Is it hard? Yes, it is. Is it a daily ongoing thing? Yes, it is. But so is hope. Hope is something we can choose every morning when we wake up, and take to bed with us at night, and know that we have it. We have hope, and we can get recovery. So that's my story. And if anybody has any questions, I would be more than happy to answer them.
It's a great story, Cheryl, and I hope you keep telling it always and always, because we know that people are helped by hearing that they are not alone, that other people are going through similar situations, and that they have chosen hope, and that every day is a step closer. So thank you so much. We really appreciate it.
You're welcome.
I know that you
Thank you for
can't
letting
see.
me share.
Oh, absolutely. I know that you can't see the chat, but you're getting some thank yous, and then a question. Did you start your recovery after the coma, or did you still struggle with using afterwards?
I still struggled with using afterwards. Um, it was a wake-up call, yes. I can't deny that, but it was hard. It was still hard because I was still learning so much about myself, about my disorder, and I still hadn't gotten a total grip on why I was using and drinking. That came later on as I journeyed along, but
And I do think it's so important for us to understand that there's always complexities. There's always,
yes,
more than one, two, three things going on. To try to separate those things out and deal with them is a huge challenge.
I know. I'm a certified recovery coach now, and one of the things that stood out so much in training was the fact that people don't wake up one morning and say, "Hey, I think I'm going to start drinking and using." It doesn't happen that way. So that that really burned in my brain.
There was another question. What was your turning point that made you stop and turn around toward recovery?
I had wanted to all along, actually, but each time it seemed like lies become truths to, at least in my journey, they did. And some of those lies were, I wasn't good enough. I wasn't, nobody cared if I was here or if I wasn't here. I wasn't important to anyone. And the whole thing is, and well, another one, I couldn't make anybody happy. But the whole thing was, I had to come to the realization that I myself was not happy. I myself was the one that wasn't feeling good enough. I was good enough. I mean, my daughters now, one of my daughters wrote in high school about how I was the strongest person that she knew. And when she read this writing to me, I think she was in like 7th or 8th grade, it blew me away because I did not see myself in that way. So I think as I got older, I started learning more about myself, becoming more self-aware. Journaling was a huge thing for me too, because sometimes when I didn't know what I was feeling, all I had to do is start writing and everything would come out. But I can't really remember a specific time that I stopped drinking and using. It just kind of fell away, I guess, as I journeyed into my recovery, if that's a way of putting it, as I became closer to really getting that recovery under my belt and hanging on to it. I didn't really relapse because I was using all along, so I never got to a point where I stopped using and then relapsed. It just fell away through a lot of prayer. I know that.
Yeah. Well, we want to thank you so much for being a part of this and for sharing your story. It's inspirational, and we hope you'll join us again sometime. Let me see if there's another question for you. Would you say that when your mental health symptoms got better, you became more involved in that treatment, that your substance abuse treatment also became easier to handle?
Definitely. Yes. Whoever asked that question, yeah, for sure. As I got a grip on my mental health, because I was definitely duly diagnosed. So as I got more of a grip on my mental health, that's actually when the substance use started dissipating more and more. I started realizing I didn't need to use anymore. I started liking myself. I started, becoming well. So yeah, that's a definite for sure.
It looks like that is all the questions for you, Cheryl.
Okay.
So thank you so much. I know you'll probably pop off, but thank you so much for sharing your day with us.
Okay, thank you.
So today's, the second part of today's session is entitled New York Matters, Medication Assisted Treatment and Emergency Referrals. And our presenter today will talk about what MAT is, what medication assisted treatment is, I should say, why it is important aspect of harm reduction, linkage to treatment, especially in regards to emergency departments and the New York Matters program. So let's meet our presenter. Caleigh Loughran currently serves as a program coordinator for New York Matters. She recently completed her bachelor's degree in psychology at the University of Buffalo. While pursuing her degree, Caleigh gained experience in the medical field, working as a patient care technician in an emergency department, a nursing assistant, and as a research assistant on a clinical research program. Caleigh plans to continue her education and attend medical school. So welcome, Caleigh. It's great to have you here today.
All right. Well, thank you, Lisa. Thanks for having me. And thank you, Cheryl, for sharing your story and for your introduction there. So hi, everyone. My name is Caleigh Loughran. I am the program coordinator for New York Matters. Today, I plan on doing a little high-level overview of medication-assisted treatment and all of the different types. And then we'll go into more about the New York Matters program, what it is, and where it is in the state. So I just want to start out with 3 primary objectives just to kind of lay the groundwork for the rest of the presentation. So we know that opiate use disorder is a chronic disease and it should be treated as such. It is the equivalent of somebody having diabetes or heart disease or any other chronic diseases that we see in the emergency department or in medicine in general. Second to that, opiate use disorder is a severe and life-threatening disease. And again, it needs to be treated as such. Unfortunately, just like other chronic diseases, if our focus and energy is not put towards opiate use disorder, unfortunately, people will die. And then lastly, the treatment of opiate use disorder typically requires the use of medication. So this is, of course, medication-assisted treatment, or MAT. And then the terminology is actually starting to kind of switch over to MOUD, which is medications for opiate use disorder, or MOOD. So I'll probably use those terms interchangeably within the presentation, but just know that I'm speaking about the same thing. So how do we diagnose opiate use disorder in the first place? So by utilizing DSM-5 criteria, you can take a look at all of the various symptoms of opiate use disorder here, the black bullet points. So having a substance use disorder is defined as by having at least 2 of the symptoms listed here, if not more, within a year's time frame. Another important thing to point out here is that tolerance, or having to use more in order to reach the same effects, or withdrawal and experiencing withdrawal symptoms alone. So those 2 alone, they do not necessarily imply that an individual has opiate use disorder. So somebody can be opioid dependent and be dependent on opioids, but they don't necessarily have opiate use disorder. And then lastly, it's important to note that we determine opiate use disorder, it's really not one size fits all. So not, 2 individuals may have completely different symptoms and it may affect them differently. So we kind of can base different cases based on severity. And so we can diagnose someone with mild, moderate, or severe opiate use disorder. And the way that we determine this is depending on how many symptoms from this list that particular patient exhibits. Another thing that I wanted to point out here is the co-occurring psychiatric disorders. So as you can see in the diagram, the orange section are those who are diagnosed with both substance use disorders and mental illness. So this is something that we see. And then on opposite sides of the spectrum, as you can see here, there are patients who are diagnosed with just a substance use disorder, and then all the way on the other spectrum, those who are just diagnosed with a mental illness. So just something important to recognize here. So again, opiate use disorder needs to be treated just as any other chronic illness would be. Unfortunately, simply abstaining from opioids doesn't have a very good success rate, and patients aren't able to typically be in treatment as long or as successful as others who may utilize other forms of treatment. So then the question becomes, how is opiate use disorder treated in the first place? So this is where the medication-assisted treatment component comes in. So again, treatment of a chronic, life-threatening, severe disease. And then the one thing I really want to point out before we go into the different types of MAT is that medication-assisted treatment is not substituting one drug for another. Medication-assisted treatment is evidence-based, and it has very successful outcomes for many patients that utilize this form of treatment. So when you think of MAT, or if someone's talking about MAT, they're really talking about 3 different types of medication. We have methadone, buprenorphine, which you might know more commonly as Suboxone, and Naltrexone, which you might be familiar with as Vivitrol. So these are the primary different types of MAT, and they all react at the opioid receptor a little bit differently, and we'll talk about those differences. So methadone is a full agonist, and what this means is that it fully activates the opioid receptor. So it's going to activate that receptor at a low degree for a long period of time. Secondly, we have buprenorphine. Buprenorphine is a partial agonist. So this means that it's going to partially activate the opioid receptor. And this is really one of the preferred medications within medication-assisted treatment, because it's going to activate that receptor just enough to keep the patient out of withdrawal, but it's not going to activate it enough to make them high or anything like that. And then lastly, we have naltrexone. Naltrexone completely blocks the opioid receptor, and this is called an antagonist. Another note about blocking the opioid receptor, naloxone, also known as Narcan, which reverses opioid overdoses, that also completely blocks the opioid receptor. So then this slide here just goes into a little bit more depth on the different types of MAT, so methadone, bup, and naltrexone. Just one difference that I do want to point out here, it could be an advantage to some and then a disadvantage to others, but methadone, in order to receive your dose, you need to go into that clinic or that treatment organization every single day. So it's a very structured program, and you need to, it's under supervised conditions in which you need to take your dose. So for someone who has a job or who has other family obligations or maybe just some other commitments, this treatment model might be a little bit difficult for them. So that's where I think buprenorphine provides a really flexible and great alternative for many people, because for buprenorphine, you receive a prescription just as you would any other type of medication. So you go pick it up from the pharmacy and can take it at home, just like you would any other medication. So this allows you to have a job and meet any other requirements or commitments that you have outside of treatment, of course. So I think that's just one of the benefits of bup as compared to methadone. So what are the benefits of MAT? One of the huge ones is, of course, is decreased mortality rates. So if we take a look at this chart here, and we take a look at the green bars, so the mortality rates of the general population, and then compare that to the red bar underneath, those are patients with opiate use disorder undergoing no treatment at all. And we see that mortality rate absolutely skyrocket. And then if we take a look at the bottom, the blue bar, so those are patients with opiate use disorder who are undergoing or utilizing medication-assisted treatment, their mortality rates are pretty comparable to those of the general population. So this just shows you, patients who are on medication-assisted treatment truly do see a decrease in mortality rates as opposed to those with opiate use disorder who undergo no treatment at all. Another question that often comes up is, how long does someone have to be on MAT for? And the short answer to that question is a long time. The most successful people within treatment are going to be patients who are maintained on their medication-assisted treatment for years, if not for life. So as you can see here, patients who are only on it for a couple of months or even a year aren't as successful in treatment as those who are maintained on their medication-assisted treatment for a long period of time. So again, specifically in regards to buprenorphine, patients who are maintained on a dose of buprenorphine for a long period of time have greater treatment retention as opposed to those patients who are tapered off of buprenorphine in regards to their treatment retention or their retention in treatment. So another thing I wanted to talk about is what is an X waiver and why would somebody need that, or why would a prescriber need it? So an X waiver is an X on your DEA license. So a physician assistant, or nurse practitioner can get this. It's an X on their DEA license that allows them to prescribe buprenorphine. So it is actually illegal to prescribe an opioid to treat opiate use disorder. So essentially you need a waiver to the law, and this X waiver is how you do so legally and of course safely. So again, physicians, PAs, and NPs can all get this. So it's a little bit of a mix of in-person and online training. Physicians need 8 hours of training, and then nurse practitioners and PAs need 24 hours of training. And then also just a little disclaimer here too, or not a disclaimer, but just to note, if anybody would be interested in setting up an X waiver training for any group of providers, please reach out to me and I can help assist with that. So then I also just wanted to talk a little bit about Suboxone specifically. Suboxone is one of the more commonly known forms of MAT, which you're probably familiar with. And Suboxone is a combination of buprenorphine and naloxone. So you might be wondering, why is naloxone in Suboxone? So the proper way to take Suboxone is sublingually. So you put it under your tongue and it dissolves. And when it is taken properly, naloxone is not active orally. So when you take the Suboxone as prescribed, absolutely nothing happens. However, naloxone is active intravenously. So if someone tries to dissolve a Suboxone tab and inject it, the naloxone will be active. And of course, naloxone prevents opioid or reverses opioid overdoses. So it's just kind of an added layer of protection there to have the naloxone with the buprenorphine as well, which make up Suboxone. So basically, if you take the Suboxone as directed, the naloxone does absolutely nothing. But if somebody is trying to use it in a different way, it could act as an added layer of protection. And then another question that comes up, what is precipitated withdrawal? Precipitated withdrawal is putting someone into withdrawal because of buprenorphine. So I'm going to give you a little example. So if someone were to take hydrocodone, an opioid, the hydrocodone would be on their receptors and it would fully activate the opioid receptor. So if somebody takes buprenorphine a little while after that, as we remember from a couple of slides ago, buprenorphine only partially activates the opioid receptor. So the buprenorphine will knock off the hydrocodone, and those opioid receptors will go from fully activated to only partially activated. And this abrupt change will cause the patient to go into withdrawal. And kind of the even funnier and stranger part there is, how do you get someone out of precipitated withdrawal to make them feel better? You actually give them more buprenorphine. So this also comes up in the emergency department setting, which we'll talk about a little bit later in the New York Matters presentation. But another good example is if someone shows up to the emergency room and they're actually not, they're not experiencing severe enough withdrawal, and they take their first dose of buprenorphine, it's possible that they could go into precipitated withdrawal. And then the doctor would have to explain, hey, I'm going to give you some more of that buprenorphine, more of that medicine, and it'll actually make you feel better than what you do now. All right. Then we're going to move into the next session about New York Matters. I think I'm just going to try to pull up the chat box. I thought I saw a question. So first, I'm just going to give a little summary
Caleigh,
about. Yep.
I didn't want to interrupt you, but
Oh, that's okay.
I can see the chat and there is not any new question for you.
Oh, okay. I must have saw something out of the corner of my eye.
It was probably my comment.
So just to kind of give a quick summary before we go into the rest of the slides on what New York Matters is. So we've been able to develop an electronic referral platform to officially refer patients with opiate use disorder from the emergency departments to outpatient medication-assisted treatment programs. So we'll go into the whole referral process, but first I just want to kind of have everyone think about a situation. So imagine you present to the emergency department, you're in withdrawal, you're feeling the sickest you've ever felt in your life. You're there for a little bit and then you're discharged. You're given a list with a bunch of phone numbers on it for some treatment organizations to go to an MAT clinic. Most of these numbers don't work. It's a little challenging to reach anybody on the other line. You're feeling pretty discouraged. You're still feeling sick. You weren't given a Bupe prescription or anything like that. So what happens from there? So a few years ago, this really was what was happening out of the emergency departments in Buffalo, Western New York, and I'm sure a lot of other areas as well. So Dr. Lynch, who is our founder and medical director, and a couple other providers or physicians within UBMD emergency medicine, really thought about this and said, hey, there has to be a better way that we can get these patients referred from the ERs to these outpatient treatment facilities, get them started on Bupe, get them a prescription to get them to that first clinic appointment and all that kind of stuff. So that's kind of how New York Matters was born a couple years ago. And, it's evolved a lot since those early days when referrals were all on paper and now it's completely electronic. But that's just kind of how everything started. So what kind of treatment would you want? Would you want to leave the emergency room with a referral, with a Bupe prescription, with a medication voucher to cover the cost of that prescription, and a referral to a peer? I definitely know what kind of treatment I would want. So just kind of think about that. This graphic here, it kind of has all the different components of the Matters program. I'll point out a couple, the first being the electronic referral system. So that's the primary part of Matters and what we'll really get into today, get into some detail. We'll also talk about the medication voucher program. So we've been able to develop this program. All Walgreens and Wegmans locations participate in the state, as well as some independently owned pharmacies. But we're able to subsidize the cost of patients' buprenorphine when they are discharged from the emergency department. Also, just the Bupe waiver training. So Dr. Lynch and a couple other UBMD doctors teach a bunch of waiver trainings in hopes to get as many emergency providers waived as possible. And then also just one quick thing that I wanted to point out, we have a great explainer video. It's like a high-level overview of what the Matters program is on our website. Feel free to take a look. We also have a whole bunch of resources there and a map of all the participating locations. It's newyorkmatters.org. So feel free to take a look or show any of your colleagues who might be interested. There were three kind of objectives or goals, I think, when the program first started. First was prescribing. So they wanted to reduce any sort of irresponsible opioid prescribing that was occurring in the emergency departments. Second to that, providing access to MAT in the emergency department. So initiating patients on Bupe either in the emergency department or sending them home with a script for buprenorphine. And then lastly, referrals, providing rapid referrals so patients can be in front of a new prescriber at a clinic of their choice within a day or 2 days or 3 days, but pretty quickly. To give you a general idea of where the Matters program is today, we can take a look at this map. This is also on our website, so feel free to take a closer look. But our largest network and where the program started, of course, is here in Western New York. Second to that is going to be the capital region. We also have some sites in Oneida County and just added some new ones in Dutchess County. We've been talking to people in Syracuse and Suffolk County and a few sites within New York City Health and Hospitals. So it really is starting to expand across New York State. If anyone works at a hospital or a clinic and might be interested in participating, please feel free to reach out to me and we can definitely chat. This document here is our mission, vision, and values document. So when the program first started and we were able to go out to the clinics and kind of talk with people to see which clinics we would participate with, I think there's just a couple of things that this document really boils down to, being that the clinic will accept any patient that's referred to them. So it doesn't matter if the patient is completely uninsured, if the patient is a polysubstance user or any other things that might come with the patient, it doesn't matter. All of the clinics who we partner with accept any patient referred to them and work with them, within their circumstances. And then we're going to jump into the protocol. So this protocol, also on our website, feel free to take a look. Essentially, if a patient presents to the emergency department and they're in acute withdrawal, they're going to receive their first dose of bup in the ER. From there, our recommendation is that every patient is provided a 4 milligram BID buprenorphine prescription for 14 days. This 14-day prescription, we ask them to prescribe 14 days for a couple reasons. First, this allows for some flexibility on the clinic side. And secondly, we don't want the patient to have to go through any sort of medication lapse. We want to make sure that they are set to go to that first clinic appointment. They'll have medication until they can get there. So this is the second part of the protocol. We have the referral process, which we'll talk more in depth about in just a couple of slides. We also recommend that the patient, family, friends, whoever might be with the patient that day, are offered naloxone kits before they're discharged from the ER. And then lastly, our voucher program. So if the patient
Caleigh,
yep.
I hate to interrupt, but I just wanted to ask
okay.
this question while it was hot.
Sure.
Megan is asking, what if they are abusing their prescription?
Yeah, so in the emergency department, the provider will check iStop to see if they have any recent bup prescriptions or maybe other opioid prescriptions or anything like that. But that's definitely something that's monitored on the provider side. And then another thing that I'll point out too is it's totally the provider discretion when the patient presents to the ER. So if they feel they've received too many bup prescriptions in too short of a time span or anything like that, that's totally their discretion. But we ask that patients are always referred. So they're always referred to treatment, regardless of any other circumstances. So lastly here, Lastly here, just the voucher process. So if a patient has Medicaid or is uninsured, they automatically receive a voucher. I'll talk about how they receive that in just a couple of slides. But they can take that to any one of our participating pharmacies and get up to their first 14 days of bup completely free. So that's their prescription that they're getting out of the emergency department. That can be completely free for them. And then again, we participate with all Walgreens and Wegmans locations in New York State, as well as some independently owned pharmacies. So this is what the iPad looks like. This is in all of the hospitals where where Matters is implemented. The provider and the patient will work together to fill out a quick form. And at the end of it, the patient will have an appointment at their desired treatment organization, typically within 24 to 48 hours of that initial clinic visit. And then just a note too, so the actual referral website, it's simply a website, it's not an app, so it can be accessed on a computer as well, and that's housed on the health commerce system. One of the main reasons why we like to use an iPad in the first place is so that the patient can play an active role in actually completing their own referral and kind of taking the first step there. So this page, the patient will fill out. There's some basic contact information, and then at the bottom, you'll see what type of health insurance does the patient have. So this is where if they indicate they have Medicaid or no insurance, This is a question that'll automatically generate a voucher for them if they indicate that they have Medicaid or no insurance. This is the second half of that demographic page. So the patient is still filling this out. There's just some medical history questions, couple mental health history questions, and then would you like to be contacted by a peer in recovery for support? So in all of the regions where Matters is implemented, we work with local peer organizations. The patient can choose to opt in or opt out of this. If they choose to opt in, their contact information will be sent over to the peer organization, and then they reach out typically within 24 to 48 hours of that initial ER visit. And then the last question on this page, select the referral location. If you were to click this drop down, you'll see all the participating emergency departments. You choose which one you're at, and I'll explain why that's particularly important in a couple of slides. Now the iPad can be handed back to the healthcare professional or whoever might be helping to complete the form, and they'll answer a couple of questions. So one of the top questions there, it's actually the second question, you select the referral setting. So this is where you're selecting if the referral is coming from an emergency department, is this an EMS referral, is this a police referral, an OBGYN referral, et cetera, and then the questions that come after it sort so they're only applicable to that particular setting. We primarily work with emergency departments, but we're really opening it up to other referral sources as well. We've recently started to work with the Buffalo Police Department and Cheektowaga Police Departments, and they've been able to offer some referrals to individuals who they come in contact with. So just to give you a general idea, if a patient is in the emergency department, we would like to know, were they given their first Bupe dose in the ER? Were they given a prescription for Bupe? Were they offered a Naloxone kit? And then what was the reason for the visit in the first place? Now for the most important part, the patient has the opportunity to choose which treatment organization they would like to go to and on which date. This map will automatically sort based on the patient's home zip code. So on the left-hand side here, you're able to see the zip code. This is a zip code that they entered on that first demographic page. And then all of the red icons that you can see are all the different clinic locations that they can choose from. If you click on any one of those icons, you can see a little bit more information. So the clinic name, its address, and then what types of MNT they offer. All the clinics who we partner with, of course, offer Bupe, but then we also indicate on here if the clinic offers methadone or naltrexone, just so the patient can make a more informed choice. So let's say the patient, definitely wants to try methadone. They've tried Bupe in the past, doesn't work for them. There's no point of sending them to a clinic that doesn't even offer methadone. So that's just an added way for the patient to make a more informed choice. This here is the list view. So it's the exact same information that was in the mapped view, but instead in list format. So the patient will choose the clinic location and the appointment date. One important thing to note here is they're not choosing the exact time of appointment, and I'll talk about that in just a couple of minutes. But they select the appointment, and then they submit the referral, and a few things are going to happen on the back end. First, all of this information will fax back to the referral site. So it'll fax back to the emergency department. It will have a printout of all the information that was completed, the voucher, if the patient was eligible for the voucher, and some Bupe discharge instructions. That hard copy can be handed directly to the patient and they're good to go. Secondly, all of this information will fax over to the clinic. The clinic is then able to reach out to the patient and schedule the exact time of appointment. So that's where that is figured out. Everything is also emailed to the patient if the patient inputted an email address. Just, another layer of protection there so that the patient has all of that information that they need. And then lastly, if the patient indicated that they would like to be linked up with a peer, their contact information is sent over to the peer organization. And then for the voucher, so that'll be emailed to the patient and it'll also print to the referral site. This here is an example of what
Caleigh.
the email looks like. Yep.
Caleigh, can I interrupt just for a second?
Of course.
You said that peer organizations are given contact information of patients.
Mm-hmm.
How do they know which peer organizations
Yes.
to contact?
So in each region, we kind of identify a peer organization as like a catch-all. So all of the peer referrals for that particular region goes to that one organization. So for Western New York, the Erie County Health Department, they received a grant and they were actually able to hire some peers. So for Western New York, if you opt into a peer referral, that's where your contact information is sent over to. Also, a lot of our clinic organizations, sometimes they are able to offer a peer linkage as well. So sometimes, that might work out before the other linkage. So it just kind of depends region to region. But here, all of the referrals do go to the Erie County Health Department.
Okay, great. Thank you.
Yep. So this is just a quick example of what the email looks like. This is the Bupe discharge instructions. And then at the top, you're able to see which treatment organization the patient chose and on which date. Also, just a note, the patient's able to choose an appointment as soon as the next business day. Typically, patients are able to be seen by the treatment organization within 24 to 48 hours of their ED visit. This is what the voucher looks like. So on the left-hand side, you can see all of the various pharmacies that we participate with. And then on the right-hand side, there's just some information for the pharmacies on how to actually redeem the voucher. So most of this we already talked about, but just to point out, I think one of the ways that this referral process has worked so well in so many different regions of the state is that it's applicable anywhere. So it doesn't matter the size of the hospital or the geographic location, but this same referral process can be applicable to any different setting. We're also able to loop in the voucher so we can cover the cost of someone's medication, the peer linkage, so someone else reaching out to the patient to see if they need any help getting to that first appointment. We really like the use of the iPad so the patient actually can play an active role in completing their own information for that referral. And then lastly, it's really a simple process for ER providers. No phone calls have to be made from the ER. The actual referral form, when you go through it, is very, very quick, only takes a couple of minutes, and then they're really set to go from there.
Someone had a question.
Sure.
Megan was asking, can someone already established in a clinic get a peer through this program?
Yes. So I'll leave my contact information, and I think it's on the last page, but we're able to send direct peer referrals to the Erie County Health Department as well. So if they're already linked up, with a treatment organization, but they'd like a peer referral, we can, I think they have a phone number too I can look for and share with the group, but you definitely can be linked with one of their peers for sure.
Okay. And you'll be sharing this, this PowerPoint with us, so I can send it out to attendees,
Okay.
correct?
Yep, that sounds good. And then just the last slide here that I kind of wanted to end on, is this working? So I will admit this data is a little bit old. It's ended in 2019. And unfortunately in 2020, we did see an increase in opioid related deaths. But from Erie County's peak in 2016, and then down to 2019, we really did see a decrease in opioid related deaths in Erie County. So with Matters and a bunch of other community programs, we really were able to see a decrease, which was great. So that's all I have. If anyone has any questions, please feel free to reach out, or we can answer them now. And also I encourage everyone to take a look at the website. There's a ton of more resources and information there at your disposal. So thanks everyone for listening.
Thank you, Caleigh. Can you stop sharing?
Yep, let's see here. There we go.
There we go. Okay, let me see if there are any more questions.
Sure.
Okay, not so far. How did you get involved in this program?
Yeah, that's a great question. So I graduated from college in May of 2019, and I was looking for a job in the area. I'm actually not originally from Buffalo, But I saw this job posting, thought it was very interesting, thought it was something, that I would enjoy. And so, yeah, that's kind of how it started. I was hired as a program coordinator in June of 2019, and have been there ever since. Yeah, so I think recently, within the past year, a big part of my job has been working to expand the Matters program and the Matters concept to other regions of New York State, which has been very unique and a very great opportunity. But yeah.
So I don't know how many of you were part of the Choosing Hope last year, but Caleigh and Dr. Lynch did a informational session for us. And we actually had some folks very interested in getting into the, at that time it was Buffalo Matters program. If anyone is interested, please let us know and we can get you connected to Caleigh and Dr. Lynch. If there are any questions, please put them in the chat. I don't see any. I think Cheryl is still with us. Wanted to say thank you again to her and thank you to Caleigh for spending time with us today. And we'll talk about next week a little bit. Next week's topic is billing and coding considerations and COVID-19 impacts on opioid use. Our speaker is Julie Gutowski, who's the Senior Vice President of Administrative Operations and Business Development at Spectrum Health and Human Services. So we look forward to that. Caleigh and Cheryl, thank you so much. And thank you all who attended the session. Please feel free to contact us. I will be sending out the PowerPoint slides this afternoon. And you can go to that evaluation page link that is in your follow-up email that probably won't reach you until tomorrow. But thank you so much.
Thank you, Lisa, and thanks everyone for tuning in.
Have a great day.
You too.